Hello, my name is Kevin McKenzie. Today I will be giving a presentation on the topic of clinical reasoning and decision-making and how this affects paramedical practice. Throughout this presentation, I will explain exactly what is meant by clinical reasoning and decision-making in the context of paramedicine, how paramedics approach gathering the information to make these decisions, and finally specific cases and situations where this judgment can be challenged. All fields of health require their practitioners to exercise clinical reasoning and decision-making, but for paramedics this is especially important. This is due to the fact that paramedics spend the majority of their time as clinicians in locations a significant distance from any allied health services. This means that paramedics must rely on their training and experience to inform their decisions, often in high-stress circumstances. In order to do this, it has been proposed by Amanda Blabber and Val Nixon that paramedics use a combination of intuition and analytical decision-making methods when making clinical judgments. They have also proposed that newer and more recently trained paramedics tended to rely more on analytical and empirical evidence-based decision-making, whereas more experienced paramedics relied more on intuitive decision-making in clinical settings. This leads to newer paramedics having a tendency to tunnel vision on provisional diagnoses, and more experienced paramedics not changing approaches that have been shown to work previously. This combined intuitive analytical model reflects the need for the constant personal development within the field of paramedicine, as too much reliance on either approach detracts from clinical reasoning and decision-making. Given how dynamic the cases that paramedics attend often are, the idea that paramedics can simply follow a set of instructions for all cases is simply unrealistic. As such, paramedics are expected to exercise their best judgment on how to approach the management of their patients by drawing upon their personal and professional experience and training. In order to do this, though, paramedics must first be able to understand the cases they are attending. When evaluating patients, paramedics are usually encouraged to focus on differential diagnoses over provisional diagnoses. This is due to the inability to make a definitive diagnosis in the pre-hospital setting. Paramedics, therefore, need to be both aware of what are the most likely conditions the patient is suffering from, whilst also being aware of the fact that the patient could actually be suffering from an unusual presentation of another condition. Therefore, paramedics should try to gather as much relevant information as they can without tunnel visioning on what seems to be obvious at the time. Paramedics should also be prepared for the case that they are attending to change significantly while they are on the scene and adjust their clinical priorities accordingly. In order to achieve this, the systematic approach to patient care is championed by both the Queensland Ambulance Service and ambulance services around the world. By having this set framework to build upon in any given case, it minimizes the risk of contributing factors being ignored and patients deteriorating due to not having their true medical needs met. Throughout the use of the systematic approach to patient care, paramedics must make judgments on whether their patient meets the criteria for certain procedures, or require further investigation through assessments such as the neurological or perfusion status assessment. While these assessments may not be able to make a definitive diagnosis, they do enable paramedics to make informed judgments on what course of action to take next. As an example of clinical judgment separate to the systematic approach, less formalized protocols such as always conducting an ECG if an elderly patient presents with abdominal pain or heartburn are adopted by most paramedics based on their personal experience and education. Another example of this would be always transporting an elderly patient who has fallen and hit their head, regardless of their presentation, due to the risk of subdural bleeding. Paramedics also individually develop judgment on which cases require more aggressive interventions, such as IV morphine versus methoxyflurane or paracetamol. The drug therapy protocols, especially for analgesia, intentionally give paramedics flexibility in when to utilize any given treatment. This is because the QAS recognizes that clinical reasoning and decision-making is essential in the pre-hospital setting, as no two cases will ever be identical, and to try to make guidelines for every possible case is never going to be viable. While guidelines for treatment do exist for paramedics, these are by no means exhaustive. This results in paramedics often being forced to adapt these protocols to suit the situation. An example of this would be the use of droperidol in cases where you have an agitated patient. While they may have an SAT score of 2 or greater, and therefore be indicated for their use, especially in manic individuals, it would be very much up to the individual paramedic's clinical judgment whether their use is actually necessary. While droperidol has been seen to be very effective at reducing aggressive behaviors in a study conducted by Emergency Medicine Australasia, its use was also seen to result in increased rates of non-compliance with emergency services in future interactions. Approaching mental health cases with pharmacological interventions alone can severely erode trust between health professionals and the public. Therefore, in my opinion, sedation should be held as a treatment of last resort when de-escalation through other means simply isn't viable. At the end of the day, our patients are people with thoughts and feelings of their own. By keeping them informed and involved in the decisions surrounding their treatment, patients are much less likely to feel like they are being ignored, and therefore less likely to become agitated in the first place. Patient-centered care should inform decisions made in all cases, but is especially important when dealing with people in mental health crises, as they may already feel like they're being excluded or treated poorly. While clinical decision-making is an essential component of paramedical practice, it must be supported by robust guidelines and education of practitioners. If this is not the case, paramedics will inevitably make decisions that result in adverse patient outcomes. An example of clinical judgment that resulted in negative outcomes was seen in the case of Mason versus the state of Queensland, heard during 2018. Without going into exhaustive detail on the case, it concerns a woman by the name of Jennifer Mason who called QAS in 2002 reporting severe difficulties breathing. The decision to withhold the use of adrenaline that was made by the paramedics who arrived on the scene at the time were, by today's standards, not the correct ones for someone suffering from a severe respiratory distress, and likely resulted in Jennifer's suffering hypoxic brain injury. The reason that was stated that adrenaline was withheld was due to the ambulance officer attending the scene exercising their clinical reasoning that oxygen via bag valve mask and intravenous salbutamol administration were the appropriate treatments. It wasn't until the patient deteriorated further during transport that adrenaline was finally administered. By this point, however, the adrenaline had limited effect, and it was deemed likely that she had already suffered from hypoxic brain injury. This is a good example of clinical reasoning and decision-making resulting in a negative outcome for a patient due to a faulty assumption, which in this case was that adrenaline should not be a first-line treatment for severe respiratory distress. While the exact party to blame for this misunderstanding cannot be certain, ambiguity in the existing drug therapy protocols and the training of the officers attending likely contributed to this failure of clinical reasoning. This case should serve as a stark reminder for paramedics not to assume that their judgment or the protocols that they follow are infallible. Constant education and recognition of blind spots in clinical experience are essential for proper clinical reasoning and decision-making. Finally, probably one of the most significant clinical judgments a paramedic can make is whether to transport a patient. In my personal experience, there is a degree of pressure to reduce the amount of resources and time dedicated to each patient, and this can, to a certain degree, inform clinical decision-making on treatment and transportation. In my opinion, however, it is almost always better to transport a patient for further assessment at a hospital, in all but the most blatantly unnecessary cases. Decision-making on whether to transport can also be complicated if the patient simply does not want to be taken to hospital, or administered certain interventions. At that point, it is the paramedic's duty to properly inform the patient of all possible outcomes of their refusal, and to attempt to work out the best possible patient cares while still respecting their patient's right to withhold consent. They must also be able to judge if a patient is capable of withholding consent or whether they need to be placed under an Emergency Examination Authority, or EEA. Throughout this presentation, I have endeavored to explain my understanding of clinical reasoning and decision-making and how it relates to paramedicine as a field. While this may be personally, the most challenging aspect of paramedical practice for me, it is also one of the most rewarding. The ability to constantly challenge yourself and improve for the future is something I seek in any employment and something that paramedicine offers in abundance. Thank you.